Please listen carefully.
Hello, Team Anaesthesia. Welcome to GasGasGas. This is the best anaesthetic science podcast for the FRCA primary exam. Our goal is to fill your brain with all this highly useful information. Now, you might be in the gym right now, commuting, or ironing your scrubs, and there's no judgment here. GasGasGas will prime your brain for the monsoon of knowledge you need to imbibe. But regardless, the revision is eventually going to end. But for now, expect facts, concepts, model answers, and the odd tangent. Now remember to check out the website, that's gasgasgas.uk. There are show notes there with all the detail, plus links to foundational reference papers and anything else useful I find for you guys. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show. Hi, and welcome to another episode of GasGasGas. I hope you've had a delightful 2 weeks. Make sure that you enjoy some pancakes this week if you're in the UK, because Pancake Day is Tuesday, the 17th of February. I have myself eaten a stack of pancakes joyfully. Today we are covering Cisatracurium. We're going to cover its pharmacology, pharmacokinetics and pharmacodynamics, think about its similarities with Atracurium, as well as other neuromuscular blocking drugs, as well as its differences. And then we're going to explore in a bit more detail the ways and means of potentiating the effects of neuromuscular blocking drugs in a patient, as well as inhibiting the function of neuromuscular blocking drugs or slowing them up. And just remind ourselves of the structure and function of the neuromuscular junction, because you certainly might get asked to start drawing that out in an exam. Anyway, without more waffle, let's get on with the show. Right, we're just going to pile straight into Cisatracurium pharmacology. If you were to look at it on an ampoule, it would be described as Cisatracurium besilate. You might see a brand name of Cisblock, which obviously is very exceedingly novel, but also Nimbex was its original brand name, which was apparently short for excellent neuromuscular blocker. It is classed as a bis-benzylisoquinolinium ester. It is one of the 10 diastereoisomers of Atracurium. It is part of the group of drugs that are non-depolarizing competitive neuromuscular blocking drugs. And just in case we're not quite sure what diastereoisomer actually really means, we just say it, don't we? Oh yeah, diastereoisomers, Atracurium. A diastereoisomer refers to an isomer that has multiple chiral centres. This leads to situations where some parts of the molecule appear in a mirror image of parts of another molecule, whilst having parts of that molecule which do not. Atracurium has 4 chiral centres. It was originally isolated/synthesised from a bucket of Atracurium, so to speak, in 1989 by Burroughs Wellcome, which is now owned by GlaxoSmithKline. Its isomer status is 1 of 10, and it is presented as a clear, colourless, or sometimes pale yellow aqueous solution in 5, 10 and 20 ml vials. The concentration in the vial is 5 milligrams per ml. It does need to be kept in the fridge, and it is quite acidic with a pH of 3.2 to 3.65. Incompatibilities-wise, this pH means that it doesn't actually play terribly well when mixed with barbiturates, propofol, and of course ketorolac, and its molecular weight is exactly the same as Atracurium's, at 929 grams per mole, so chunky molecule. Why did they really bother to develop Cisatracurium? Because we've got levobupivacaine, and we know that that's generally a bit less cardiotoxic than good old-fashioned bupivacaine. And when it comes to Cisatracurium, we all know that if someone's very histamine-y, you would avoid using Atracurium and certainly avoid using mivacurium, because you trigger histamine release. That can lead to hypotension, bronchospasm, flushing, etc. Cisatracurium, even in really quite large doses, causes very little histamine release. And when I say large doses, up to 8 times the ED95, and we'll get into that in a second. So plenty of Cisatracurium before it becomes troublesome. This is its chief marketable feature, although I'm sure if everyone here looks in their anaesthetic cupboards or in their fridges, because it should be in a fridge, the odds are they probably won't find Cisatracurium. I've seen it once in a teaching hospital and thought, oh, there's Cisatracurium there. But alas, this is why they considered all the marketing costs, all the costs of testing it and making sure it's safe, etc., in the hope that they could say, Cisatracurium, really good, when I think most of us would just reach for rocuronium in this situation, if someone's very histamine-y, so to speak. Anyhow, what about the pharmacodynamics and side effect profile of Cisatracurium? So its mechanism of action, competitive, non-depolarizing neuromuscular blocker. inhibitor antagonizing acetylcholine at the nicotinic receptor on the postsynaptic membrane of the skeletal neuromuscular junction, and that's its chief site of action, noting that it would work on nicotinic acetylcholine receptors found anywhere within that neuromuscular junction on the presynaptic as well as postsynaptic sides. Dosing, quite a small dose actually, because it's 3 times as potent as Atracurium, and Atracurium requiring about 0.5 milligram per kilo for a sensible, not waiting too long dose. With Cisatracurium, you need 0.15 milligrams per kilo, and that is a 2 to 3 times ED95 dose. You can infuse it, and it's recommended that you should give a fifth of that dose as a maintenance dose to sort of tick things along during your case. Onset-wise, naturally, if you give more, it works quicker. If you give less, it takes longer, and that's why sometimes it's tempting to give just a little bit of rocuronium or a little bit of Atracurium, accepting that you're going to be bagging the patient for a bit longer, but it's going to wear off quicker, so it's useful for a high turnover list. Because the ED95 for Cisatracurium to achieve 95% twitch suppression is 0.05 milligrams per kilo. Not very much at all. Side effect profile. So as I have alluded to, it is a very stable drug. Your mean arterial pressure and your heart rate with rapid and large boluses, less than 8 times the ED95, yield a sensible and stable cardiovascular system. There's an incidence of about 1 in 200 patients developing a bradycardia. So it's quite a forgiving drug if you were to get your dosings wrong because you're thinking about things in such tiny fractions of a milligram. It's probably better to think about it in micrograms, really. You see a 0.2% bronchospasm rate, so nice and defendable, and a 1 in 1,000 rash rate and a 2 in 1,000 flushing rate, 0.1% and 0.2% respectively. So a very safe and stable drug. Not suxamethonium with its sux apnea, anaphylaxis, malignant hypothermia risk, bronchospasm risk, bradycardia risk, muscle aches and pains risk, and that's perhaps why some people say, oh, suxamethonium, really bad. Maybe they're right, maybe they're wrong. What about the pharmacokinetics of Cisatracurium? And remember, guys, if you're not sure, this aligns pretty much consistently with Atracurium because, hey presto, it's part of that bundle of isomers you will find in an Atracurium ampoule. As with most neuromuscular blocking agents, the volume of distribution is small, 0.1 to 0.16 litres per kilo. Of note, like Atracurium, it crosses the placenta, so if you've had to do a GA section and if things are a bit awkward and your ventilation's not quite tickety-boo, maybe try and put the track in after the baby's out. Otherwise, the paediatricians are going to be scratching their heads and just wondering why the neonate just isn't breathing, even though it's clearly obvious that they've had a general anaesthetic. And metabolism. Now, you really should be able to tell me how Cisatracurium is metabolized. But if you're not quite sure, because this is your first dabble with GasGasGas, I'll tell you that the primary means of metabolism of Cisatracurium is Hoffman degradation. This is where a link between a quaternary nitrogen and the central chain is cleaved. Its secondary mode of metabolism is hydrolysis by non-specific esterases. These are esterases that are floating around, having a great time, not doing much, and they see a Cisatracurium molecule and they think, yes, I will. Remember, it is chiefly Hoffman degradation. What byproducts are there of the metabolism of Cisatracurium? And I'm sure you can remember for Atracurium. It is laudanazine. Now, laudanazine is metabolized by the liver, and that metabolite is cleared renally, but it is somewhat implicated in modifying your seizure threshold, i.e. lowering your seizure threshold. Now, this hasn't been played out in humans. There's evidence that levels of above about 17,000 micrograms per mil in plasma will cause seizures in animals. And here's another marketing angle that perhaps came about with Cisatracurium. Although you can always know these pharmaceutical companies are desperate to be like, oh yes, our drug that we've patented the synthesis of, it's miles better than this drug that's cheap and easy to use and costs peanuts. Because naturally they did the studies to see how much laudanazine you end up with a dose of Cisatracurium versus Atracurium. And no, ultimately, Cisatracurium yields quite significantly less laudanazine than its Atracurium pal by an order of magnitude or so, 190 to 200 mics per litre for Atracurium and a mere 20 to 38 mics per litre for Cisatracurium. So if you've got a patient with a really knackered liver who needs to be paralysed on intensive care for a long period of time, and you're worried about laudanosine accumulation because they've been having seizures, then you might think about Cisatracurium, but that seems to be a chain of unlikely events, and we don't really keep people paralysed for that long. The half-life of Cisatracurium is 22 to 35 minutes. The clearance of Cisatracurium is 4.6 to 5.7 mils per kilo per minute. 4% of it will be found in your poo, and 10 to 15% escapes your body unchanged in the urine to paralyse unsuspecting fish, maybe. So we've mentioned a few reasons why you might be tempted to pick Cisatracurium. We know we like it because it doesn't cause histamine release. We delight in its minimal metabolite laudanosine status, perhaps. And naturally, these benzyl lysoquinolinium compounds are less dependent on the liver and the kidney for the effect of the drug to ease. And that's what we're really interested in. You don't really mind if the patient's full of a drug, if that drug's not doing anything. But ultimately, did it catch on? Not really in the UK by the looks of things, especially not now. Cisblock or Nimbex, perhaps used more elsewhere, where they've got more dosh. So where would you put Cisatracurium in your mental model of how it fits in relative to other neuromuscular blocking agents? So, in terms of potency, Cisatracurium is 3 times the potency of Atracurium. Vecuronium is 4 to 5 times the potency of Cisatracurium, whereas Rocuronium is 1.3 times less potent than Cisatracurium. Now we know clearly that Rocuronium is less potent, and that requires larger doses. However, we also know that this is clinically useful, as you will achieve a greater concentration gradient between the plasma and the effect site, and ultimately you will deliver more agent to said effect site. This is the Bowman principle, whereby potency is inversely related to onset. Therefore, you get a faster onset time. Potency is inversely related to onset. Bowman's principle, one to remember. Anyhow, time for a brief mention about the sponsors of GasGasGas, Teach Me Anaesthetics. These guys are behind an excellent single best answer question resource. Firstly, I took the joyful, challenging and intermittent bashing through their 1100 plus questions which they have written for the FRCA primary exam. Now, I secretly loved it, and there are plenty of questions to test your knowledge. When I was studying for the FRCA primary, it did not exist, but there were other packages online. These cost a lot more, and they didn't really seem to reflect the content of the exam. Whilst doing them, I came across rehashed MRCP questions, which was not terribly inspiring and left me pretty cheesed off. Whereas these single best answer questions have been built from the ground up. They have not sniffed an MCQ in a past life. They are based on the anaesthetic science you need to know, and there are explainers with all the questions, so it builds your knowledge as you work through them. There is a multitude of ways you can study these questions. You could choose to do a random battle with 1100 plus questions, or split them into subject area. You can go back and redo the ones you've gotten wrong. It's very malleable. So if you've been thinking about which question resource you might want to get your hands on for the exam, you shouldn't really look any further than Teach Me Anaesthetics. If you reckon it's for you, all the links to Teach Me Anaesthetics from GasGasGas are affiliate links. So if you're signing up through one of those, you're helping to support GasGasGas. So if you think you're going to go for it, click a link with me. You know you want to. You'll not only be supporting your exam preparation, but you'll be supporting your 100% favourite Tell Your Nan Over Sunday Lunch podcast, which is of course GasGasGas. So I know in the Rocuronium episode, all that time ago, we spoke in relative detail about the neuromuscular junction from a sort of physiological perspective. The concept that we're going to explore in the latter half of this episode is considering how neuromuscular blocking agents are potentiated, thinking about patients insensitive to neuromuscular blocking agents and patients who are sensitive to neuromuscular blocking agents. I'm going to take this opportunity to just remind you about the neuromuscular junction, its structure and its function, before we get into the potentiation, sensitivity, insensitivity. So you will find yourself thinking about the structure of this junction first. You have a presynaptic membrane where you will find the terminal bouton of your motor nerve. That's full of acetylcholine-filled vesicles ready to exocytose and dump into the synaptic cleft or synaptic gap between your excitable neuronal membrane and your excitable postsynaptic muscular membrane. That gap is only 70 nanometers, so pretty damn heckin' small. And that postsynaptic membrane is deeply furrowed to increase the surface area and subsequently achieve a significant density of nicotinic acetylcholine receptors, 10,000 per micrometer squared, which is many. Functionally, an action potential nails it down that motor axon at 100 to 120 meters per second if it's an alpha motor neuron, and at the presynaptic membrane, voltage-gated calcium channels open in response to membrane depolarization. The calcium that's got into the cell activates snare proteins, opening our dear acetylcholine vesicles into the synaptic cleft. This all spills out into the synapse abundantly, and there is a big safety factor. So 3 to 5 times more acetylcholine than necessary is dumped into the synaptic cleft. Now, in the synaptic cleft, you will find acetylcholine esterases that rapidly tidy up, but some of it naturally gets across and activates nicotinic acetylcholine receptors. Do not get nicotinic receptor and muscarinic acetylcholine receptors mixed up. Nicotinic muscle, muscarinic, think nervous system, parasympathetic nervous system, that thing that has G protein coupled receptors. That's what a muscarinic receptor is, GPCRs of various varieties. Nicotinic is muscle. And these are pentameric, ligand-gated, ligand signaling molecule, transmembrane, cation, positive ions, channels that let sodium into the cell. When we say cell, I mean the muscle membrane. The sodium influx depolarizes that membrane, and in these deep clefts you will find volt-gated sodium channels that continue this depolarizing activity and lets loads of sodium pour into those muscle cells. This sodium triggers the calcium channels of the sarcoplasmic reticulum. These are our ryanodine receptors, to release the calcium stored in the sarcoplasmic reticulum, which goes on to cause excitation, contraction, coupling, etc. Other important things to note is that there are some presynaptic nicotinic acetylcholine receptors that also get triggered by the release of acetylcholine from the neuronal membrane of the neuromuscular junction. And this activates mechanisms within that terminal nerve ending to push some more vesicles of acetylcholine towards the nerve ending. This goes some way to enabling that nerve to respond to repeat signals to contract. So that was a whistle-stop tour of the neuromuscular junction, guys. So now let's think about ways we can mess with the neuromuscular junction and stop it working, because they could well ask you in the exam. So tell me about how skeletal muscle can be paralysed or something to that effect. And it truly depends on the site of action of the agent. And you would be remiss to say, there are depolarizing and non-depolarizing neuromuscular blocking agents, because you've really just hit the end there. You've hit the nicotinic receptor side of things. But if you stop that nerve ending synthesizing acetylcholine, or make it synthesize slightly duff acetylcholine, then that nerve ending won't work. And there is such a thing called hemicholine, which you can give to rats, probably shouldn't give it to humans, that blocks acetylcholine synthesis and subsequently will cause paralysis slowly but surely. You could deplete your stores of acetylcholine, and that's what tetanus toxin does. You could prevent acetylcholine from being released from that nerve ending. Gentamicin gets involved here. Magnesium gets involved here. You can naturally alter the state of play with neuromuscular blocking drugs, but you should also think that there are other drugs that act upon the nicotinic acetylcholine receptor. Chiefly volatiles can bind to a site on the nicotinic acetylcholine receptor and cause a degree of blockade. You've probably seen it where someone's got a MAC of 1.1 and you do their train of 4 and it's, there's pretty significant fade on the go there. And then you turn off the gas, turn up the oxygen and think, see if I can just wait a little bit longer before I give the neostigmine and the glycopyrrolate, obviously, to see where we are. And you turn it off and then you let the MAC get down to maybe 0.6 and think, I don't really want them to be waking up and being paralysed. That would be bad. I'll just check the train of 4 again. And, your amplitudes are better. And naturally, a degree of time has passed. Your neuromuscular blocking drugs will have clearly abated in those few minutes, but you've also knocked a lot of volatile anaesthetic out of them. In terms of comparative potencies, a MAC of 1.7 of isoflurane is equivalent to 1.3 of sevoflurane. So it is quite synergistic, and that's why with a MAC of 2 sevo, you could intubate someone, although they do cough and buck, and it's not very nice. But there are other drugs. I'm sure you're thinking, James, you need to list this and you need to say that. We've covered magnesium, we've covered gentamicin, but lithium also potentiates neuromuscular blocking drugs. Lithium mimics sodium, and it does indeed squeak through these sodium channels when they're activated into excitable tissues. However, cells aren't very good at getting rid of lithium because they don't normally have to deal with that from an evolutionary perspective. So the lithium can accumulate intracellularly. High intracellular concentrations of lithium displace intracellular potassium, leading to partial depolarization of these membranes. So someone with a bit of lithium on board might be a bit floppy, and someone with a lot of lithium on board may be rather floppy. So now I hope I've got you thinking a little bit broader about how you might block the function of muscles in somebody, or at least how you should perhaps approach this in the exam to sound a little bit more broad. So what about patients who are insensitive to neuromuscular blocking drugs, i.e. they might need a bit more, or the drugs wear off quicker? And you can probably break this down into other drugs that relax skeletal muscle and other drugs that alter the pharmacokinetics of neuromuscular blocking agents, as well as disease processes. And you could think about patient insensitivities and patient sensitivities to neuromuscular blocking drugs, hanging those sub-classifications off of it. So other drugs that mess around with skeletal muscle. The real one that comes to my mind is dantrolene. And dantrolene is an intracellular skeletal muscle relaxant. It antagonizes the ryanodine receptor. So if no calcium gets out of the sarcoplasmic reticulum, excitation, contraction, coupling can't really take place. However, are you going to go mixing dantrolene, which is a nightmare to mix, just to be a bit smug with your anaesthetic? No. But we do have the odd patient who takes dantrolene for twitchy muscles, muscle spasticity, etc. in an oral preparation, and we might just be a bit thoughtful and think, well, okay. You're probably thinking, hey, Dr. Gas, if something causes intracellular skeletal muscle relaxation, surely that patient's going to be more sensitive to neuromuscular blocking drugs. And the question really becomes is, have they just yesterday started taking dantrolene? You would expect them to be rather floppy. Or have they been on it for donkey's years and actually they are a little bit floppy, but they have chronic exposure to a drug that has led them to compete with that drug on a muscle level, i.e. they might actually have more ryanodine receptors synthesized than your average bear to try and counter the chronic consumption of a skeletal muscle relaxant. And I'm fairly sure there are papers to say that if we all dabbled in a tickle of rocuronium every day, we would progressively become a little bit more resistant to rocuronium as we would put more acetylcholine receptors into our neuromuscular junctions. So if anyone fears IM flyby paralysis by some rogue person with rocuronium or Atracurium, well, start today. And this concept of having too many nicotinic acetylcholine receptors brings me to think about Burns patients. And Burns patients have, again, a surfeit of these nicotinic acetylcholine receptors, courtesy of those burns. They've got loads of extrajunctional receptors. And arguably, you could think, well, maybe they're going to need more non-depolarizing muscular blocking agents. And the question is, the jury's out. I would say. Some bits of the internet suggested, yes, you should get a bit more. Others didn't. And this is because if you think about the distribution of rocuronium throughout a human, we know that the rocuronium is not just hightailing it to the neuromuscular junction and, passing go, taking 200 quid and going straight there. It will bathe other bits of the muscle anyway. So the concentration at your neuromuscular junction is probably the same if you're burnt or not burnt. But you just might end up blocking some rogue receptors that shouldn't really be there elsewhere, that aren't really involved in muscle contraction particularly anyway, because they're not innervated normally. However, remember, don't give them sucks, because if you were to trigger all those receptors, they would all open up and you would dump all the potassium from inside your slightly angry muscle and cause mischief. So what about ways you can pharmacokinetically alter the behaviour of these drugs with another drug? And this kind of applies more broadly than just rocuronium, atracurium, etc. First thing that should jump to your head is drugs that induce liver enzymes, therefore speeding up the metabolism of drugs that are cleared by the liver. And you're thinking, right, rocuronium and vecuronium. But then also think, what about drugs that might increase the amount of protein in the blood? And phenytoin and phenobarbital increase the production of alpha-1 acid glycoprotein. And atracurium is relatively partial to alpha-1 acid glycoprotein, and therefore you'll have a smaller unbound fraction of your dose of trac and have a prolonged onset time. Now, unfortunately, I'm not quite 100% sure if chronic use of phenytoin or phenobarbital is particularly protective against local anaesthetic systemic toxicity because whilst your local anaesthetic also binds to alpha-1 acid glycoprotein, phenytoin at least is a sodium channel blocker as well. So if you've got local floating around blocking sodium channels causing mischief, and you've got phenytoin floating around blocking sodium channels causing mischief, it's probably not going to help your local anaesthetic systemic toxicity. And if anyone is having seizures due to local anaesthetic systemic toxicity, probably wouldn't reach for phenytoin. Pretty sure the Quick Reference Handbook says propofol and benzos. Benzos first for seizures, propofol second for seizures. But also note that antiepileptics have a membrane stabilising effect. As you would expect, they stabilise your neuronal membranes in your noodle to reduce the chance of a seizure, but they also have effects on other excitable membranes in your body. That's why phenytoin can lead to ventricular arrhythmias, and people need to be on monitoring if you're having phenytoin loading for seizures. Oh, very interesting things to think about. What about patients who are more sensitive to neuromuscular blocking drugs? And you should be able to name some conditions and some drugs. And you can break these conditions down into those that are of an autoimmune basis that impair muscle function and those that are particular to the neuromuscular function of a person, i.e. motor neuron disease, myasthenia gravis, Guillain-Barré, myotonic and muscular dystrophies, whereas your autoimmunes are going to be polymyositis and dermatomyositis and lupus. Drug-wise, you might be thoughtful and think, well, do I want to give gentamicin to my patient with urosepsis and myasthenia gravis? You should think twice. If it's a one-off dose, maybe you're all right. But if you're on that 7 milligrams per kilo regimen where you're calculating the peaks and the troughs, you might find yourself with a slightly more myasthenic patient than you began with. Although admittedly, a myasthenic patient with an infection could have a crisis purely because of the infection. It is worth, when anaesthetising these patients, to be thoughtful and considerate with regards to your drugs of choice to achieve neuromuscular blockade. Now, if you have to block them, rocuronium and cigabadex, rock at reduced dose and cigabadex at an appropriate dose, is considered an appropriate means of managing them. However, if you just need a tube in but you don't need to be paralysed, remifentanil is perhaps our friend here, because we know we can sneak a tube in if we get someone pretty flat with a dose of Remi. Well, thank you everyone for listening to yet another episode of Gas, Gas, Gas. I quite enjoyed digging into the long grass with Cisatracurium, but I certainly more enjoyed thinking about interesting ways that you can inhibit the function of the neuromuscular junction. I do wonder if there is a IV dantrolene dose that you can intubate someone with. When we get to an episode on dantrolene, which we will, maybe I'll look at that in a bit more detail just for a laugh. In 2 weeks' time, we're going to cover either vecuronium, pancuronium, or both, depending on how much meat there is to either of those. And then we will cover cigabadex and perhaps an episode on some of the more historic neuromuscular blocking agents, just for a laugh, D-tubocurarane and galamine. But regardless, happy Friday. Hope you have a lovely weekend. Ahoy, Team Anaesthesia! You've survived yet another episode of Gas, Gas, Gas. Now, if you found it useful or harrowingly awful, please like and subscribe, drop us a star or 12, and follow with whichever podcast platform you find yourself using. Please leave a comment or ping off an email if you think I need to square something away. Now, there are a bunch of ways to support the costs of Gas, Gas, Gas. From buying me a coffee, to venturing forth via an affiliate link, to the horde of joyful SBA questions from Teach Me Anaesthetics. Those links are on the website and in the show notes. Speaking of website, definitely check out gasgasgas.uk for the show notes, the diagrams, the details, the references. Now, we all know, guys, that this is a bucket of content to consume, and it is like drinking from a fire hose. So I want to finish by saying, take it day by day, don't overcook yourself, don't freak out, and keep studying.